Okay.
You can start now.
A very good evening to all. Welcome everybody to the Clinical Practice Oriented Webinar Series, CLIP. So this is the 10th webinar of the CLIP series, and we have already had 9 such webinars in the past year. So the screen coordinators for today's webinar will be Dr. Malika MN. She is Civil Assistant Surgeon Anesthesia at Government General Hospital, Kurnool, Andhra Pradesh, and Dr. Akhila Ganoji. She is Senior Resident at Government General Hospital, Medical College, Mahbub Nagar, Telangana. So I request Dr. Akhila to please take over and proceed with the session. Thank you.
Thank you, ma'am. Good evening, everyone. A warm welcome to all our esteemed senior members, coordinators, and distinguished panelists and delegates who have gathered here today for clinical practice-oriented webinar series. Today's topic is perioperative blood transfusion, which is very crucial not only for anesthesia practice but also for other healthcare professionals. Blood transfusion protocols and newer blood products are updated every now and then, so each and every healthcare practitioner should be aware of it. I express my sincere gratitude to Dr. Sukhminderjit Singh Bajwa sir, Honorary Secretary ISA National, for his constant support and guidance throughout this CLIP webinar series. May I request sir to address the gathering. Over to you, sir.
Thank you, Dr. Akhila. I think we are starting the CLIP series after a gap of almost 3 months because there were certain hiccups during these last 3 months and certain limitations we could not start. And we will starting with the CLIP today and the CRISP series in the first week of the April. And the topic is the blood transfusion. It's a very important topic, and all the 6 panelists and the moderator, they are masters of this topic. And I think this is the best platform. You can ask any question to them because there are so many myths, fallacies, and so many, facts and figures which are not clear, there are so many doubts. I think everything can be clear today itself. So you don't let go these people. These 7 people are there to answer everything. And I hope they will be helping us enriching our knowledge. So without wasting time, and soon I think some few GC members are also there. Our program head, Dr. Manoj Kumar, and just GC members are also there. And soon our president and academic chairman will be joining. They are busy right at the moment. So without wasting time, we should start this session. So Akhila, you go forward and start from where you have just left.
Yes, sir. Thank you, sir. Now, I request program head for today's Dr. Manoj Kumar, sir, Honorary Treasurer, ISA National, to please speak a few words.
Thank you, Dr. Akhila. A very warm welcome, our Secretary, Dr. Bajwa, our Program Coordinator, Dr. Madhuri Kurdi Madam, Nishant Sahai, and Moderator, Dr. Kirandeep Sandhu Madam, and all the panelists to this clip series. I say already conducted 9 clip series previously, 3 months before. So my best wishes to all of you. Thank you.
Thank you, sir. Now I will be introducing the moderator and all the 6 panelists for today's session. We have Dr. Kirandeep Sandhu ma'am, who is a senior consultant and HOD at Wokhart Hospitals, Nasik. Ma'am's areas of interest are risk mitigation, quality and patient safety in anesthesia. Ma'am received President Appreciation Award from Maharashtra State ISACON 2023. She is a winner of Best Patient Safety Initiative World Health Congress. She received National Award for Excellence in Healthcare Initiative CMO Global Asia, Mumbai 2015. Now I'll be introducing all the 6 panelists, starting with I welcome Dr. Lalit Kumar Raigar sir, who is a senior professor at RNT Medical College, Udaipur. Sir's areas of interest are ENT, maxillofacial surgery, obstetric and pediatric anesthesia. Sir published over 60 publications He is a former president of ISA Rajasthan. He organized Raj Visakon 2023. He is an editorial board member, former editorial board member of Indian Journal of Anesthesia from 2013 to 2016. He is the AOA founder, member, treasurer, and vice president. We welcome you, sir. Next, I invite Dr. Shivaram sir, who is the HOD of Transfusion Medicine, Manipal Hospital, Bangalore. Sir's areas of interest are immunohematology. Am I able to hear, sir? Audible, sir?
Yeah. Carry on. Yeah.
One second, sir.
We are really fortunate to have exchange transfusion expert with us. Akhila, please continue.
Ma'am,
you're muted. You're muted.
Sir has many awards to his credit. He got Lifetime of Ancient Centurion Blood Winner, and he's also the editor-in-chief for the Global Journal for Transfusion. So it's a pleasure to have you here with us. Yes, Akhila, please do continue with the introductions.
Yeah, Akhila, continue. Yeah, fine, Akhila, continue.
Sir's areas of interest are immunohematology and therapeutic apheresis. Sir achieved Lifetime Achievement Award. Ma'am, 1 second, ma'am. I'm unable to open.
Okay, Malika, please carry on with the introduction.
Ma'am, am I audible, ma'am?
Yes, please carry on.
Sorry for the disturbance, ma'am. Sir's areas of interest are immunohematology and therapeutic apheresis. Sir has achieved Lifetime Achievement Award from ISBTI, Centurion Blood Donor Award from Lions Bloodline. He is an editorial-in-chief in Global Journal of Transfusion Medicine. We welcome you, sir. Next, we have Kalyani Surya Dhanalakshmi, ma'am. Kalyani Surya Dhanalakshmi, ma'am, who is an additional professor and HOD in Department of Anesthesiology, AIIMS BB Nagar, Hyderabad. Ma'am's areas of interest are oxygen system, obstetric anesthesia, orthopedic and laparoscopic anesthesia. Ma'am has published over many national and international publications. She has won COVID Warrior Award. She has conducted many workshops and CMAs. She is one of the national and state faculty. We welcome you, ma'am.
Thank you.
The next panelist will be introduced by my co-coordinator, Dr. Malika. Dr. Malika, please take over.
Thank you, Akhila. Good evening, all. Our next panelist is Dr. Indu M. Sen, ma'am, Professor of Anesthesia and Intensive Care, PGI, Chandigarh. Madam, area of interest are pediatric anesthesia, acute pain management, perioperative stimulation training. Madam achieved President as AIOA and Associated Indo-Ophthal Anesthesiologist in 2023. Madam did her fellowship in Indian College of Anesthesia, IAPA, and Madam is a founder member of Neonatal Anesthesia Society and AIOA. Madam is instructor for BCLS programs and ACLS programs, FCCS and PPLS and pediatric stars. Madam has numerous international and national publications and through three book chapters in her credit. We welcome you, ma'am, for this webinar.
A very good evening to all of you, and thank you, Akhila.
Our next panelist is
Yes, Dr. Akhila.
Okay, ma'am. Our next panelist is Dr. P. Vinita, ma'am, Senior Consultant and of Emergency Medicine, Tata Main Hospital, Jamshedpur. Area of interest is trauma, hemodynamic monitoring, and mechanical ventilation. Madam achieved gold medal in DNB anesthesia. She is the Young Research Award at the International Conference of Clinical Pharmacology. Madam has numerous national and international publications. Madam is a faculty lecturer and conducted many workshops at ISA, ISCCM, regional and national conferences. Madam, we welcome you for this webinar, ma'am.
Thank you very much.
And our next panelist is Dr. Ridhima Sharma, Associate Professor of AIIMS Nagpur. Madam, area of interest are pediatric anesthesia, regional anesthesia, research methodology. Madam, awarded for Young Talent National Award, Dr. Cobbs Pediatric National Award, and first prize at International Conference of ICA, ATLS instructor. Madam is the member of National Academy of Medical Sciences and nominated as master trainers to train the doctors by the Health Department and NHM, Uttar Pradesh. Member of the Pediatric Perioperative Life Support course. Madam published numerous national and international journals and 10 book courses. We welcome you, madam, for this webinar.
Thank you so much.
Now I request our esteemed moderator, Dr. Kirandeep Sandhu ma'am, to proceed this session.
Very good evening to each and everyone here. My heartfelt thanks to Bajwa sir for the opportunity to interact with such a distinguished panel. They say in a silent world, one voice is loud. We have 6 stupendous superlative voices here to answer all the queries on perioperative blood transfusion. But I would like to begin by saying my sincere welcome to each and every of the esteemed member of ISA who has joined this webinar. Your presence here gives validity to the intent of sharing and learning from each other the best clinical practices for safe and excellent anesthesia. So thank you so much for joining this. You're most welcome to post questions. We'll try to make it as interactive and take each and every query that comes here. In India, we have approximately 14.6 million blood transfusions that take place annually. We are still short by 1 million transfusions, which don't happen because we don't have the resources. And out of this, 40% come in the purview of medicine, and more than 56% are in the perioperative settings. And the decision to transfuse patient is a critical decision, which is most of the time done by anesthesiologists. But this is not something which is without dilemmas and controversies. So let's try to find out the best answers that we have for the time being to question what are the best practices for the blood. So I would request everyone, get into your comfy clothes, grab your favorite beverage, put your seatbelts on, and let's enjoy this 1 hour discovering the blood transfusion. And since time and tide waits for no one, I will straightway, with the blessings of our teachers and the divine net gods, start this webinar. Dr. Kalyani, I would like to start with you. With a case scenario which is pretty common. We have a 68-year-old female patient who's a known hypertensive. She had a PTCA stenting done 10 months ago, and now she's posted for bilateral TKI. She takes aspirin and clopidogrel regularly since she was stented. And on your preview, she has a hemoglobin of 8.2. So it's very common to get surgery patients which are on the borderline, on the low hemoglobin, and it's an elective surgery. Would you be comfortable administering anesthesia? What happens if a surgeon operates on low hemoglobin? And how would you treat this anemia? Would you give a transfusion or not? What would be the trigger?
So thank you very much for inviting me in here. So the way I would go about it is look at the evidence. We have found that anemia per se causes increase in mortality and morbidity both at 30 days and 90 days. So obviously anemia has to be corrected. Now, is this an elective or an emergency? It's an elective surgery. We should give adequate time. We should reassess the cause of anemia. So the blood transfusions has now changed gears. It's patient blood management system. So there are several pillars to it. And most importantly, preoperative correction of anemia by conservative methods, which would assess what is the cause of anemia. And as we all know, in India, iron deficiency anemia would be a major cause. Nearly 30 to 40% are because of iron deficiency anemia. So further management would look at investigating serum iron ferritin levels. transferrin saturation levels, which are less than 100 micrograms or less than 20% in an inflammatory state, would with a raised CRP would indicate anemia, or in a less than 16% in transferrin serum ferritin levels would again indicate anemia. Now, if it's not, we would have to further, rule out CKD or the GI malignancy. Per se, as anesthetists, we do not do so much of investigation, but she should be investigated and corrected for the anemia before we would take her up for surgery. And I would not go for preoperative blood transfusions. The conundrum here is anemia causes increased mortality, morbidity, and amongst the people who there is the restrictive group and the liberal group. I'm unfortunately or fortunately in the restrictive group. I do not like to give blood transfusions unless it is purely indicated, because blood transfusions per se also have shown to have an increased morbidity and mortality in the postoperative period. So,
point very well made, ma'am. Giving a blood transfusion just to expedite an elective surgery is not justified anymore. The mortality and the long terms, and even our surgery colleagues do understand the negatives this brings. So giving a little time in elective surgery, having informed consents, making patient apart. Dr. Shivram, I would like to know, what test would you suggest in a patient who comes with an anemia in pre-op? What immune hematological test would be done? One, to kind of optimize, and the others to ensure that there is adequate availability of the blood when this patient does go in for surgery. Dr. Shivram, sir?
Sir, you're muted.
Sorry. Thank you, Dr. Kiran. I think Dr. Kalyani has highlighted the point that people who take blood actually tend to spend more time in the hospital, have more complications than those who don't take blood. So our goal is always not to transfuse blood. But that we will get an idea only when we do some basic tests. In this lady, she's an aged lady with hypertension scheduled for a major surgery. And so I think minimum we came to know our hemoglobin is low because we did a hemoglobin. So I would say in today's HCBC is a basic requirement to know the hemoglobin and hematocrit, then which will also then the platelet count, because when you take up a patient for major surgery, we expect a certain minimum threshold of platelets. So platelet count also you will come to know. Then although WBC count is not so important, leukocytosis or leukopenia also are associated with adverse outcome during surgeries. That's something else that is also you will come to know. But then having classified it as in case of anemia, next point is to identify the cause of anemia. So you will go in that direction. So these are some tests which are absolutely required. Then probably in this patient, since she is a hypertension with a major surgery, you probably do a creatinine and maybe a LFT also, though it is not always recommended a LFT. At least serum creatinine would be required because of her hypertensive status and her age. Then if she is on any anticoagulation, then I would like to do a prothrombin time, INR or APTT as well if required. So this will give us an idea of what is the condition. Is she going to have a coagulopathy? Is she a candidate at risk for increased bleeding and those things?
Sir, would you encapsulate the current liberal and restrictive that ma'am had mentioned? That what are the current triggers for restrictive and what are the current for a liberal transfusion? You can choose whichever category you want to, but what are the triggers?
So for a long time, anesthetists believed in this rule of 10, which said that unless you have 10 gram %, we should not give anesthesia, and so 10 gram was followed. But now I'm sure over the last decade or decade and a half probably, this has slowly dropped to 8 gram %. So when we mean restrictive transfusion, it refers to a hemoglobin below 7. But by that I mean 6 gram per deciliter. In the absence of risk factors today, 6 gram per deciliter is good enough. Whereas if a patient is compromised either because of cardiac function or pulmonary function, then or an aged patient with a risk factor like hypertension, diabetes, then probably you will not be comfortable with 6 or 7. You would maintain 8 gram per deciliter. That's about the transfusion trigger. Will not go only based on hemoglobin. Probably you look at other clinical parameters, but this is one of the things. Then platelet count. You are taking up the surgery for a major surgery. This is a bilateral knee replacement, something like that you said. So I presume in any major surgery, the requirement is to have 50,000 platelets. Although all of us have 1.5 to 4 lakhs per microliter, we need a minimum of 50,000 platelets to undergo a major surgery. And you need 1 lakh platelets if you have to undergo an ophthalmic surgery or neurosurgery. It's a higher count, like 1 lakh per microliter.
Yes. Indu ma'am, I would just want to ask, how is it different in children? If this was a child coming for an elective surgery, what would be the values, the hemoglobin, hematocrit that we would be looking at? How are neonates and children different from adult when it comes to blood requirements? Indu ma'am? Ma'am, please unmute yourself.
Yeah. And when we talk about children, it's a wide range of age, from neonates to 12 or maybe 18 years. So we are mainly concerned about infants. Right, there we have to be more careful, and if it is an elective procedure, as Dr. Shivaram said, that we can wait. But if it is an emergency procedure, say it is a hernia, so we may proceed even if the hemoglobin is 7 or 8 milligram.
And ma'am, how would you keep the trigger for intraoperative? Would you transfuse, or would you give any transfusion, or delay the surgery for some time, build the child up?
That will depend upon the type of the surgery, whether it is elective or emergency. If it is an emergency, definitely we have to go ahead with it. Then we can resuscitate side by side. For elective procedures, we may wait for some time. Say, as I said, hernia, if it is a reducible hernia and the hemoglobin is low, maybe we can transfuse and then take up.
Lalit sir, whenever we are starting a blood transfusion, what are the formal formalities? How important is the consent, and how long is that consent valid when we take a cluster? You may not transfuse, but can we use the same consent for some time? How does the consent work in blood transfusion?
Madam, this is important part. One is there is legal formalities, because blood is under the controlling of the drug and controlling departments. So if there is we are not able to take the legal formalities. That is, one is consent, that has to be informed to the patient that what are the benefits and adverse effects of the blood transfusion. That it is necessary because of the patient condition. It has to be informed and get informed to patient consent as well as relatives, and it is better that if we get a neutral consent, that neutral may be a nearby patients, so there is no compulsion, so they are neutral. So it is necessary that we have to take the consent. Second one, if the consent validity, how long? Suppose we have decided that the patient will get 2 blood, 3 bloods, and even after patient not improve, like that is intraoperative part or later on. So then we have to again inform the patient and relatives that now patient's condition is, there is need of, as per the clinical condition as well as investigations, that we need more blood transfusion. So we have to take further consent in that date. The date should be mentioned on date and time.
Yes. Yes. Now that we have kept our triggers extremely low to the point that we are uncomfortable, obviously the second pillar becomes very important, that we would have to definitely cut down on blood loss, because there are no margins here to lose from when we are not transfusing blood at those hemoglobin levels, right? Dr. Ridhima, what can we do? What are the other adjuvant strategies in the pre-op, intra-op period that we actually use that to reinforce these restrictive strategies to cut down on blood loss? Otherwise, if we have significant blood loss, we are looking at mortality and so many other morbidity things going at a hemoglobin of 8 or 7, So what are the measures that the evidence suggests now to cut down on blood loss?
Good evening, everyone, and thank you, ma'am, for asking this very important question. So, organizational consideration for minimizing intraoperative bleeding begins in the preoperative phase and include identifying the patient at risk, followed by triggering pathway and initiating appropriate intervention. So there are basically three pillars: that detection and treatment of preoperative anemia, if there is anything, reduction in perioperative blood loss strategies, and physiological reserve of anemia, including restrictive transfusion. So if the patient is having a history is very important, like all other comorbidity we ask, if the patient is having an iron deficiency anemia, it should be easily corrected, especially patient posted for a elective surgeries. And it is very important to know the history of an anticoagulant and any antiplatelet patient is taking, because they generally and mostly interfere with the coagulation and increase the perioperative bleeding. So it is important to stop these anticoagulants and all the antiplatelets at the appropriate time. If could not be stopped, then bridging therapy should be initiated. And also the anesthesia strategies has to be managed with the surgeon taking it as a multidisciplinary approach, like regional anesthesia can be preferred over the general anesthesia, and our ventilatory strategies can be kept like low PEEP and other things to avoid intraoperative bleeding. Especially patient positioning is very important, because in the prone position, especially if you are not taking care and the IVC is getting compressed, there is engorgement of the epidural vessels and there is increased blood loss. So all these things are very important when you are taking. And most important thing is the thermoregulation. Hypothermia is a very important thing that you have to be very vigilant and cautious, because even a 1 degree decrease in the temperature can increase blood loss to approximately 16% and increase overall burden of blood transfusion to 22%. So other techniques including hypotension anesthesia is very important, lowering the BP. Especially in ASA1 patient, the guideline says you can decrease the mean arterial pressure to 30%. So other thing, people use opioids, IV inhalation, sedation. Now remifentanil is also available in India. So all these things you should use as your technique to avoid any extra intraoperative blood loss. Coming to other technique, there are also normovolumic hemodilution that has been used, in which patient blood is removed and replaced by a crystalloid to maintain the intravascular volume, and hypovolemia hemodilution, in which blood is drawn without withdrawing blood and aiming lowering the hematocrit. So there are also techniques for the cell salvage techniques, which has used many of the things. And very important thing is to use the adjuvant like antifibrinolytic drugs like tranexamic acid has been used. And in a woman trial done in 2017, RCT shows that in more than 20,000 patients who used tranexamic acid, 3 hours of surgery, there was markedly decrease in the blood transfusion. And CRASH trial also shows that. So that is very important. Point of care is very important to, rotem and TEG to see. Suppose if you are, there is a fibrinogen is low, you can give cryoprecipitate. So point of care is also very important. Coming to the last thing, there are also now available fibrin sealants like fibrinogen and thrombin, gelatin thrombin, although they are costly, but if your patient and your institute permits, you can also use them. These are very important things. And desmopressin has also been used nowadays, especially in the European guidelines in trauma. They said if the patient is having any platelet dysfunction, so you can use a desmopressin. It is antidiuretic hormones and can cause transient rise in factor VIII and Waldron factors. And PCC concentrates are available to immediately reverse vitamin K depletion factors. So all these things are very important. Coming to the preoperative, intraoperative, and most important thing is surgical techniques. Use of diathermy, minimal invasive surgeries, and cell salvage. These are the techniques that we can use. And definitely tourniquet use, proactive approach to ligate your vessel before it bleeds. It's a very important. And post-op also,
yes, very rightly said. There are multiple prongs of ways of addressing the blood loss, I'm very interested to see the questions which are popping up, Ridhima. And there are 2-3 of them, so I'm going to address this now itself. Dr. Leena, Dr. Gulset, the question about PEEP. What is the optimal PEEP which will kind of help in the blood loss? Because I see there is a bit of a confusion that what PEEP levels are there. See, I think the point that Dr. Ridhima is trying to make, because there are about 6 questions on PEEP, is that you actually don't want to keep very high PEEP and you want to ensure there is good venous return. So if you can take this, that how does low PEEP help in the blood loss, Ridhima? That's the query most people haven't understood when you were making the point. Yes.
There is not a clear-cut thing that this much PEEP will increase or decrease. It is all arbitrary and depending upon your patient condition. But you should keep in mind, sometimes we started with the 6, 7, 8. So you should start with a lower PEEP to, so that your ventilatory strategies are not compromised. But definitely you don't want to decrease the cardiac output and, all that bleeding, you want to avoid it. So at least you start with a minimum 5 to 6 and then you can increase it or decrease it depending. But this is one of the technique that has been mentioned that can help to reduce your blood loss. So unnecessarily high PEEP should not be used, and starting from the lower level is the caution point of caution that I want to highlight in this.
Dr. Malika, the point is not that the low PEEP is helping. It is avoiding the detrimental effects of the high PEEP, which would actually compromise. So the point is to avoid high PEEP, so your blood loss is less. And Dr. Preeti, Dr. Anita, there are so many people who are like tranexamic. Yes, it's a proven strategy for not only for cardiac, for orthopedic, for obstetrics, liver traumas, and we'll be coming to massive. It has a major role to play in reducing the blood loss. 1 gram stat. So yes, it is definitely here to stay. Yes. Since audience is asking us question, let me ask the audience one question. Akhila, can you put the audience question slide 42 on the main screen, please?
Yes, ma'am.
Yes. See, the point we are trying to see is when we are giving blood, it's not that we are trying to get one magical RBC numbers. Fundamental is to improve the oxygen delivery to the tissues, which is going to give the optimal physiological condition for body to undergo surgery and deal with whatever stress it is doing. So the question to the audience, and you can keep posting the answers in the chat box, is that once you transfuse the blood to a patient, how much time do you think it takes to equilibrate hemoglobin after a blood transfusion? Do you think it is 15 minutes? Do you think it is 1 hour? Do you think it is 24 hours? Or do you think 1 week? So when we have given the blood, the equilibrium of hemoglobin concentration, how much time it takes? I will leave the audience to ponder on this while I move on to Dr. Shiv. So there are many questions, right? When we get the blood, how do we store that blood? What is the ideal way of warming a blood? When we receive there, what are the timelines and for how long can we keep the blood at room temperature? And in what duration should that blood go? Akhila, thank you for the questions. We can come back to the main screen, but I'll let the audience think that how much time does it take to equilibrate and when should we send a blood sample after transfusing a blood? Dr. Shivram, can you please enlighten us how to actually transfuse the blood?
Okay. So coming to blood transfusion, again, there are two rules. One is rule of 30 and another is rule of 4. So the rule of 30 refers to 30 minutes. A unit of blood, when it is removed out of the refrigerator, controlled temperature, reaches 10 degrees centigrade within a matter of 30 minutes. At 10 degrees centigrade, the bacteria inside, if any, inside the blood begin to multiply and they can cause harm to the patient. So the idea is to start the blood transfusion within a maximum of 30 minutes after receiving the blood from the blood center and complete the transfusion, let's say a unit of red cell, over a maximum period of 4 hours. So when I say maximum, I'm not saying you should transfuse every unit over 4 hours. Probably it's a good practice to give it over 2 hours or 2.5 hours. in most patients who don't have a cardiac compromise. But you could have some patients with cardiac failure in whom you may not even be able to transfuse in 4 hours also. In such situation, you must ask the blood center to aliquot it and give it to you in 2 batches. So this way, you will be able to complete each unit within a maximum period of 4 hours. So coming to plasma and platelets, are less viscous. They pass through the filter very easily. So mostly 6 RDP or 1 SDP or 1 FFP can be transfused over 30 minutes very easily, 20 to 30 minutes. That is the time period. If you are not able to transfuse the blood within 30 minutes, then you should return the unit to the blood bank and then ask them to reissue. So we will take it back if it comes within 30 minutes, because then we know even though the cold chain is broken, it hasn't exceeded the time limit. Or if you can establish a mechanism by which cold chain is not broken, even for 2 hours, then we would still be taking it. But why we don't take it back is you may keep it outside on the table, put it back into the refrigerator to make it cool and give it back to me. That is not acceptable. Whereas if you had a box which changes color when the temperature is broken, then we don't mind taking back the unit of blood.
But sir, this is a very practical problem, because sometimes when you have a rare blood group, you have to ensure that you have a blood. And if you haven't had the blood loss, you issued the blood, you have a blood in hand. Now you don't want to, we are trying to save the blood products, but the blood storage unit does not take it back because it's 30 minutes, So you don't want to transfuse a blood just. So is there any like a gray zone if it hasn't been, what do we do with it? Now, do we just transfuse it if they're not taking it back, or this is going to be discarded, a wasted resource? Like the practical problem of you've issued a blood and now you have not used it, I think Shivram sir's screen has frozen for a minute, but I'm delighted to see the audience response. Dr. Pankaj, Dr. Mahib, Dr. Ligura, Dr. Rohini, Dr. Guru, Dr. Seema, Kiran, Dr. Leena Patil. Everyone has got it. Yes, it does take 24 hours to equilibrate. However, in anesthesia, nothing is simple and straightforward. This is when the patient is stable and is not losing. But if a patient is bleeding, there is an ongoing process. Then, of course, we will be submitting. So once you have given a blood, we could technically do the blood test anytime after 15 minutes, 4 hours, 6 hours. But it depends upon how the bleeding. The equilibration effect, as everyone has rightly pointed, is 24 hours. Do we have sir's screen back, Akhila? Okay. That's fine. No, not an issue. I'll come back to the sir in a minute. Now let's have a case scenario. There is a 35-year-old polytrauma who's wheeled into the ER. And my question is to Dr. Benita. She was an emergency medicine expert. So you have a polytrauma which is wheeled into, there is blood all over. You can see it on the trolley. It's overflowing on the floor. Patient is extremely pale, BP is 60/30. Patient has been transferred from a rural setup. There is no history of passing urine at any time, and there is no record of any blood group. Dr. Benita, when we get these patients, my question is, what is massive blood loss? How would you initiate a massive transfusion protocol in your setup? And what would be your triggers for your red cells, for your platelets, and for your plasma? Dr. Benita, ma'am?
Yeah. Am I audible? Thank you, Dr.
Yes.
For raising this scenario, because it is very common in the emergency department, cases of polytrauma coming. So this scenario that we have read out just now is definitely a case of massive blood loss. So we usually define massive blood loss if there is a loss of more than 1 blood volume over a 24-hour period, or if there is a 50% blood loss over a 3 hours period, or if there is an ongoing bleeding going on at the rate of 150 ml per minute. So now the next question is, how do we know how much is the blood volume? So there's a very simple formula. it is called the rule of 5. So I'm talking this in the context of an adult patient. So we have got 4 groups of patient. One is a fat patient, thin patient, normal patient, and a muscular patient. So the blood volume, you will start at 60, 65, 70, 75. So by 5 you go up. So that much ml per kg is the blood volume. So accordingly, we can find out how much of the blood volume is lost and whether this loss of blood volume is qualifies for a massive blood transfusion or not. So that also there is a scoring system, a very simple scoring system given by Nunez et al. And they say that if there is a penetrating injury, if the systolic blood pressure is less than 90, if the heart rate is more than 120, and if there is evidence of free fluid in the fast examination in the abdomen, if any 2 criteria are ticked as yes, then this patient most probably is a candidate for a massive blood transfusion. So the scenario that we have read out, definitely this classifies because not only this is a polytrauma, this is an extreme case of hemorrhagic shock where the patient is now bordering on organ failure. So this patient definitely needs a massive blood transfusion protocol. So before that, needless to say that we will have to do the ABCD assessment and management, airway with C-spine. And before going for blood requisition, this patient definitely needs an intubation and ventilation and optimization of the oxygenation. So then what is a massive blood transfusion? Again, by definition, if you are transfusing more than 10 units of RBCs within 24 hours, or more than 4 units in 1 hour, or replacement of more than 50% of the blood volume by any blood product over a period of 3 hours, then this classifies as a massive blood transfusion. So now the thing is, what should be our trigger? So when a patient is a trauma patient where the ongoing bleeding is there, one has to start RBC, packed red blood cell, plasma and platelet in the ratio of 1:1. 1:1:1. So at that ratio, one has to start the blood transfusion. Now, subsequent assessment and reassessment will depend on the hemodynamic stability, on the improvement that we see in the patient. So for that, we need to keep on doing the lab tests and most properly the point of care test, which is the TEG. So once we have got hold of the blood parameters, vital parameters, and the ongoing bleeding is stopped, then we'll have to check our parameters again. So the trigger would be, in a trauma patient, we would like to keep the hemoglobin more than 8 always, 8 to 10. The platelet would be anywhere between 50 and 75,000. And the PT-INR ratio should be around more than 1.5, within 1.5. So that should be our trigger. And to attain that trigger, we have to follow the point of care testing. And as needed, we have to transfuse either the blood or the blood products.
Excellent summary, Dr. Vanita. Akhila, can you unmute Dr. Shivran? He's been there because I want to ask this question. See, the packed red cells have absolutely no coagulation factor. So that's why we are going into 1:1:1, and we are trying to go into the lethal triad, which is happening in massive trauma. The simple question that comes to mind is, why not use fresh blood? It has all the components, your platelets, your this thing. What is the rationale behind using 1:1:1 and not use the whole blood in case of massive trauma where you have lost a lot of blood? There, why are we using components? This is my question to Dr. Shivram sir. And Akhila, please unmute, sir.
Yes, I'm unmuted, I think now. You can hear me? Yes. So I think that's an interesting question. Why not use fresh whole blood itself instead of using red cell, platelet, plasma? In fact, some people also tell us you want to make more money with component. That is why you don't want to give us fresh whole blood. But please tell me, how should I give you fresh whole blood in this era of NAT testing when blood is not ready for the next 24 to 48 hours, it has to undergo blood grouping, antibody screening. Then we do chemiluminescence or ELISA. Then we do nucleic acid testing. So when we have to do all these things, it takes not less than 24 to 48 hours, by which time the clotting factors have gone down significantly. The platelet, though may be present in number, it is stored at 4 degrees centigrade and not on the agitator now, because we haven't separated components. So the platelets are probably non-functional or partially functional. So the only way I can give you fresh whole blood is if I have donors standing outside the blood center who will donate, and I will do some inaccurate rapid tests, which none of us believe in. Rapid tests can be highly inaccurate, fraught with danger. So if I were to give you 6 units of improperly tested fresh whole blood, would you prefer that? Or would you prefer red cell, plasma, platelets given separately in the ratio of 1:1:1?
Perfectly answered. It's actually very hard to get fresh whole blood now because components do cut down on injudicious use. So we are giving in exact quantities to the patients they need, and it's actually harder. So there are a lot of questions which are coming. Like if we don't have blood products, can whole blood be given? The question here is that it's actually easier to get the other components. And what test do you think is absolutely mandatory for whole blood testing? So NAT testing, blood obviously costs more. So would you recommend every blood unit to be NAT tested, or is there a cost benefit ratio and you can surpass some? Or what are the essential tests for the blood which will cut down on infections and complication and must be done?
See, NAT, the most expensive test in any blood center today is nucleic acid testing, which costs 1,000 rupees. So it adds greatly to the cost. So let's keep aside NAT for some time. So basically what needs to be done before we go into NAT. NAT can be done if your center can afford it. If you are working in a private hospital and charge the patient, yes, you should be doing it. But if not, you have to get first things first, that is doing a proper blood grouping, cell grouping, and serum grouping, and antibody screening of the donor as well as the patient, antibody identification where required, giving antigen negative blood after identifying the antibody, then using ELISA or CLIA tested blood is fairly good enough, and we have used it for decades now. But more importantly, when you are doing ELISA or CLIA testing, and when you take blood from such a blood center, please ask them one question. Do you have a Levy-Jennings chart? A Levy-Jennings chart is something where we run a weak positive control, which should be picked up every day, a low positive, not a strong positive. So if that is picked up, that means that assay is very good. So please encourage people to tell them, if you don't have a Levy-Jennings chart, then I don't get the confidence to take blood from you. So please put in a Levy-Jennings chart. If you do that, blood will be fairly safe. That will make it safer, no doubt, but that cost is an issue there.
Thank you for making us appear very knowledgeable. We'll be definitely asking for the Levy-Jennings charts to our blood banks, whether they have it and they incorporate. So one question, which anyway was part of our discussion, but it's appearing so much on there, the pre-medication before blood transfusion, giving paracetamol, giving Avil, giving hydrocortisone, giving Lasix before blood transfusion. These are years and years and decades of old habits which die hard. And let's have it from the exchange transfusion guy on what do they say on these practices.
I would only say, would you take paracetamol after you got a fever or before you got a fever?
Excellent.
You wait for the fever, isn't it? If you took, all these things, paracetamol, Lasix, everything, before the reaction happened, you would be masking the reaction. The idea is to know a reaction when it happens, not just mask the reaction and allow it to fume and becomes more serious. So I personally don't believe in, and there are no recommendations to give either paracetamol or Lasix prior to blood transfusion. But we are a little scared when working in private hospitals about anaphylactic reactions when doing plasma exchanges. So only during plasma exchanges, therapeutic plasma exchanges, where we give large quantities of plasma, we are worried that one of these units may result in anaphylactic reaction. So there we prefer to give Avil and hydrocortisone. But if I worked in a government hospital where patients are far more liberal, I wouldn't use that also, even in such a situation. But maybe there is some room for using Avil, hydrocortisone to prevent an anaphylactic reaction, not otherwise. Routinely, there is no
not even
indication
for anaphylaxis, because
No.
these drugs have their times. So even for anaphylactic reactions, which would be so immediate, the drug of choice would be obviously to stop the blood transfusion, make sure you haven't started a wrong bag, and give adrenaline rather than giving any of these drugs. They would help us combat anaphylaxis. So I think we can put this practice to that, giving Lasix, giving paracetamol, giving Avil. Aving hydrocortisone has no rationale before starting a blood transfusion, and that's something that we don't indulge in. Dr. Lalit, I need to ask you one question. If we don't have blood on our hand, can we proceed for surgery? What are the legal liabilities? Is the hospital liable for non-availability of the blood? Whose responsibility is if we go and say, of course, in an emergency scenario, elective is different, but what are the legal standpoints if you start a surgery without blood on your hand and then you end up in trouble?
Yes.
Dr.
In
Lalit?
current era, it's important part. For elective, no, we have not to proceed. We have to manage, optimize the patient condition, then we have to proceed. For emergency, yes, we can proceed as a life-saving procedure if the patient condition is so much deteriorated. But we have to document it. It has to be informed to the patient, relatives, and consent has to be taken. That now patient condition is so and so. As Sriram sir has mentioned that for the blood grouping, cross matching, and testing, it requires time. So we have not to wait. In that condition, we can proceed without blood. I can share my experience that one of the rupture ectopic patient that is pulseless, and we had no doubt we can, if possible, we can take that sample. Otherwise, during operative time, we can take the sample from the, even we had taken from the blood abdomen and we had sent it. I have just intubated the patient in that condition with giving 25 milligram ketamine. The lady is near about 45 kg gold, pulseless, gasping condition, and I asked them to continue. If they want, give a local infiltration of local anesthetics. Otherwise, at present, the patient is conscious, gasping, without giving any anesthesia local, that proceed. And meanwhile, we had give resuscitation with our plasma, the Hestar, along with the vasopressor, and the surgery was done, and patient get extubated on the table at that time. And meanwhile,
when the outcomes are good, nobody is going to question it. When the outcomes are not good, then every little decision which was made obviously is going to be put on scrutiny. But it's important, if you're not getting a rare blood and you do need to proceed, the documentation processes need to, that you had made every effort to procure blood, and in the interest of a life-saving surgery there, but the documentation of making adequate effort needs to be documented so that legally later on it doesn't get to trouble you more.
Documentation of patient vitals along with sequential incidents, that now the patient vitals are so and so, so and so. That's help in the
the documentation of the critical events becomes imperative. In the ma'am, how are the children different when they have massive blood transfusions or massive trauma or something when they come there? Is the component ratio the same in neonates and kids as it is with adults?
Yes, it is same. If we do have blood products, and we are lucky to have them, it's a very good habit to calculate the allowable blood loss and then be prepared for it. And we have point of care testing, so just do a sample and find out the hematocrit, and accordingly we can transfuse and manage.
Perfect. Yes.
Kiran,
ma'am has sent a beautiful slide of point of care testing for
APG analysis. Blood gas analysis.
Yes, we will show it to the audience, definitely. And I can see a lot of questions piling up, so I'm going to start moving very quickly. Dr. Benita, this patient is still oozing. We have given 1:1. We still need to go ahead for the surgery. What is the next step in the point of care testing? What would you do when you have started with 1:1, your ABCDs, everything, and the patient is still oozing out? What next? What products?
So polytrauma patients usually go into a state which is called early trauma-induced coagulopathy. Earlier, we used to think that it happens only after giving intravenous crystalloids and colloids or because of the anemia. But now it has been proved that the trauma per se and the damage to the tissues and the endothelium triggers a cascade of reaction which goes into a coagulopathy. So to combat that coagulopathy, we always give in a ratio of 1:1:1 the massive blood transfusion. But at the same time, unchecked blood loss could also lead to a consumptive coagulopathy and the patient could land up in a DIC type of scenario. So if this patient is taken up for surgery, then definitely we would like some tests to find out which are the coagulation factors which are deficient and which could be corrected before the patient could be taken up. So for that, in addition to the PT, APTT which we do, usually they will not tell us anything about the functionality of the platelets. So in that scenario, a TEG is a very helpful monitoring modality with us, which not only gives us the clotting time, the clot formation time, the clot thickness, the firmness, and the lysis time. So all these, when we see in the curve, that will give us at what level of coagulation derangement the patient is, and whether the patient could be treated with the platelet transfusion only, or a combination of platelet and plasma, or whether we need to give cryoprecipitated or fibrinogen. Having said this, this patient should also be evaluated whether the lethal triad is still existing. If there is an ongoing acidosis that needs to be corrected before the patient is taken up. So a blood gas is very important here. Temperature of the patient, of the infusing fluid, and the ambient temperature of the ER and also the OT needs to be very well maintained, because we don't want a hypothermia happening. And of course, to correct the coagulopathy, we need to rely on the TEG, and we need to keep on transfusing the coagulation and the component factors that we needed.
Akhila, I would request you to put
So
slide 24.
In addition to that, if I may just add here,
yes,
we have mentioned the use of tranexamic acid. Now, tranexamic acid has got a specific role in trauma, because it should be given ideally within 1 hour, but we can give it within 3 hours also. That is 1 gram given over 10 minutes, followed by another 1 gram which should go over 8 hours. Now, this is something, the second dose is not given in the perioperative non-trauma patient usually. So that is very important. And in a patient especially that has gone into a coagulopathy and has started oozing, we might as well think of a recombinant factor 7A or prothrombin complex concentrate according to the availability. There are no clear-cut guidelines here, but yes, off-level use has been done, and they have been shown to improve when there is a massive bleeding happening.
Dr. Benita, there's a question that has come many times, that what is the best colloid option till the time you get blood in your massive traumas, and how much of it can you give before you get blood on hand?
So the best colloid is blood itself. So right now, we do not recommend. Yes. So right now we do not recommend giving giving other colloids, either starch or HES. They are not given because they themselves have been shown to promote coagulopathy. So maybe a liter of crystalloids, and one has to quickly switch to blood and blood products.
Yes. Now, I know that this is a question being asked too, even otherwise I knew this. Now, this patient which had come in is continuously oozing, and his labs which read right now is that hemoglobin is 3, his hematocrit is 10%, the platelets are down to 20,000, PT-APTT is prolonged, We are lucky enough to have fibrinogen levels, which is 0.5 milligram, and the patient weighs 60 kg. Shivram, sir, how do we decide how much FFP, cryo, and what is a way of actually practically calculating so that we're not wasting resources? There's a rationale and the coagulopathy does get reversed. So for this case scenario, what would you recommend?
Okay. So first I want to clarify that this 1:1:1 ratio is not any particular guideline. There have been studies showing that if you increase the ratio of red cells to plasma, you get better results. So you don't feel bad if you don't have a MTP protocol in your center and you are going by on a case-to-case basis. So let's look at this case now. This is a 60 kg patient. So we know the adults have 70 ml per kg body weight. If it's a newborn, you can calculate as 100 ml per kg. With a child, it will vary based on the age, maybe 80 or 85 ml per kg. So the total blood volume works out to 60 into 70, 4,200 ml. So this is the way we calculate blood volume. Now RBC volume is 10%, which means 10% of 4,200 is 420 ml. So the plasma volume is remaining 90%. So the plasma volume in this patient is 3,780 ml. Now, if we want to calculate and transfuse the right dose of fibrinogen in the form of FFP or cryo or fibrinogen equivalent from pharmacy, this is how we can go about. Presently, the fibrinogen level in the patient is 0.5 gram per liter. Let us say we want a minimum level of 1 gram per liter because patient is bleeding, still oozing post-surgery. That means we need to add, another 0.5 gram, 1 minus 0.5, so 0.5 gram per liter is what we need to add. Patient already has 0.5. That means for every liter, we should add 0.5 gram. What is the plasma volume? 3780 liters. If for 1 liter, we have to add 0.5 gram, for 3.78 liters, we will need to add 0.5 into 3.758, isn't it? It's just common sense. For 1 liter, this much. 3.78 liters, how much? That comes to 1.89 grams or 1980 milligram, converting it into milligram. Now, each unit of cryo gives us 150 milligram of fibrinogen at a minimum. So if I divide 1890 by 150, it tells me how many cryo to give, 12 units of cryo. But many people will be surprised to know that FFP, in fact, has more fibrinogen than cryo. The amount of fibrinogen in 1 FFP is equivalent to that present in 2 cryo. But still we need cryo because a volume of 10 FFP will be 2 liters, whereas volume of each cryo is only 20 ml. That's the reason we need cryo, though cryo needs lesser units. So 1 FFP is equal to 2 cryo. Therefore, either you can give 12 units of cryoprecipitate or half that, 6 units of FFP if you don't have cryo facility, or you can straight away go and give 1890 milligram of fibrinogen obtained from pharmacy. So this is how you can calculate how much of cryoprecipitate or FFP needs to be given. Just remember that 1 FFP is equal to 2 cryo when it comes to fibrinogen.
Each unit of cryo is 150 milligram of fibrinogen, and our target is at least 1 gram. Lalit sir, is there any difference in obstetric patients because they tend to bleed massively too? What is the fibrinogen levels that we target in obstetric population? Lalit sir?
Normally it is 2 to 4.
Yes, so that's a carry-home message.
Yeah.
Yes.
While
yes,
in obstetric it is 6 milligram.
In obstetrics, the coagulation cascade really needs to be certain because it really pains my heart that even in these times we lose young women to postpartum hemorrhage and all. There, the threshold target for fibrinogen is 2 grams. So we definitely target more in obstetric as compared to a young polytrauma patient which comes in with us.
No, even in normal patients undergoing major surgery, you should target higher levels. 1 gram per liter is the level below which you need to give cryo. That is the cutoff level. I'm not saying you should reach when I just showed calculation for 1 gram, but you should aim for a higher level. That was just a calculation.
Yes, right, sir. And it's important to know how much to give. And obviously, as Benita ma'am had said and Indu ma'am had said, it is a point of care. It's going to be a dynamic process. You keep reassessing it and you keep finding your requirements and accordingly substitute, and hopefully the least possible, which can maintain the tissue oxygenation, would do the job. Here I'd like to now, Akhila, can you put audience question number second, slide 43?
Yes,
You are
ma'am.
being a fabulous delegates which are participating. Yes. Lalit sir, there is a question about Jehovah's Witness. Dr. Rajesh will definitely address that at the end of the question section. Rohini also wants, and there are guidelines which are there, but we'll definitely illustrate those regarding Jehovah's Witness later on. But here is a question that I want to ask. Obviously, whenever we are giving blood transfusion, every time it's not going to be smooth. I have a case where a polytrauma patient has a hemoglobin of 4.9 gram, has had now a febrile reaction. He needs to undergo surgery, so we do need to give him another blood transfusion. What is the next best course of action? Do we send blood cultures? Do we do pre-storage leukocyte depleted packed red blood cells? Do we have leukocyte reduction post-storage, or do we irradiate the blood? I'd be interested to see how the audience sees what do we do when we have febrile reactions, the most common reactions that we get when we get blood transfusions. I'll give a little time. What do you think would be there? You have had a febrile reaction. And here I would ask Dr. Benita to cover the complications which we get once we go for massive blood transfusion. And then I'll come to Dr. Ridhima to address the TACO and TRALI conflict that we have when we have the complications. See, for this question, we know febrile reactions happen. But the best thing to do for this is to go for pre-storage leukocyte depleted packed red blood cell. That's the best way of avoiding the cell, because we can have post-storage reduction. We can use higher generation of filters to cut down, but the best way to mitigate this is to actually mitigate the reaction. And I know we order these there, and many times we don't realize the difference between irradiated blood and leukocyte depleted blood. Irradiated blood is for taking care of, if you have cellular components like RBC, WBC, you irradiate them, you want to cut down on the graft versus host. So when we are going for renal transplant, where we want to have less immuno, that's when we irradiate. Non-cellular components like plasma is never irradiated. You don't need to do that. And so that's only for there. So irradiation is in the transplant. For this, we ask specifically for pre-storage leukocyte depleted. Dr. Shivram, would that be okay for us when we have febrile reactions? Sir, please unmute yourself.
Yeah, that would be the right thing to do, because most of the febrile reactions are caused by cytokines, interleukins, other chemical mediators. So if you were to do a post-storage leukoreduction, these have already been released. So pre-storage leukoreduction is done on the day of collection or doing image. So this would be the best unit to do this. This is the best way to treat this. Primarily, I want to stress that there are only 3 indications for leukoreduction. When you remove leukocytes, you remove cytomegalovirus, Epstein virus, many organisms like that. Second, you prevent release of cytokines. And third, you prevent HLA alloimmunization, because HLA antigens are present on the leukocytes. So these are the primary advantages of leukoreduction. Post-storage can achieve the remaining 2, but cytokine reduction can happen only with pre-storage leukoreduction.
Dr. Bajwa wants to know, what about fibrinogen concentrates in this patient?
Fibrinogen concentrate in this? No, there is no. This patient has had fever because of red cell transfusion, I believe. That doesn't mention what another blood.
No, not this patient, not this patient.
Massive blood transfusion.
Polytrauma
patients, sir. When we are talking about blood products, yes. We will come to PCC and fibrinogens in a while. Akhila, thank you so much for putting this. And also to put into perspective, Akhila, can you put slide 33 and 35 from Dr. Indu Sen ma'ams? So putting the same information in context to children. And Indu ma'am, in infants, very small volumes are done, and we get blood in a very large containers, So what do we do? Is it okay to use small aliquots for children and from the seer and keep using it on different points? What would you do for infants? Indu ma'am?
Right. As the sir, Dr. Shivaram said that blood should be used within 30 minutes or it has to be used like maximum 4 hours. So for neonates, what our blood bank people are doing, they are giving us small aliquots. Like they split
35,
the
Akila. Sorry, yeah.
they split the unit into the smaller units and preserve it. And we get it, we have a WhatsApp group. So we get 1 or 2 units. When the one unit is started, we ask for the next one. So the chain is maintained.
Yes,
and that
and the
comes in the
orders, ma'am, for
storage
neonates,
boxes.
how do you put the orders? Is it through infusion pump or is it through, how would you give in infants?
We are using the blood set only. From the blood set, we put it in the microdrip set.
Akila, can you put slide 35 and 37?
Yeah, the slide which she has displayed, it is a very important slide regarding the
a very
assessment
important
of the
slide.
blood.
Yes.
Yeah, regarding the assessment, like the hemodynamics can be fallacious because the kids, they are able to maintain even if there is a fall in the cardiac output, they are able to maintain the systemic vascular resistance. So SVR is maintained. So by the time there is hypotension, already more than 40% of the loss has occurred. So we have to be careful about this and look
Very
for
rightly,
other
we can
clinical
miss
signs.
out on children. Absolutely right. It's a very important point. And this is a
And
beautiful
capillary refill time in the central location. That is, look at the forehead, look over the sternum, and because the peripheries may be misleading.
And yes, this is a beautiful chart which will say, because there are so many products, fibrinogen, cryoprecipitate, which one. So a very nice in pediatric patient transfusion line. How we do the same point of care testing, even in children when they are doing the blood transfusion. Thanks, Akila. Right. Now, Dr. Binita, we have done massive blood transfusion. Okay. The problem is that it comes with a lot of complications which come with it. So what are the things that we need to be concerned about when we have done a massive blood transfusion 1:1? What are the things that we are monitoring in these patients? What are our concerns that we need to follow up on?
Yeah, so that's a very important question. So before I address that question, I would like to address the query raised by Dr. Bajwa that fibrinogen concentrate. So fibrinogen concentrate usually is advocated for congenital fibrinogen deficiency as an adjuvant therapy for massive blood transfusion protocol. It has still not got the recommendation.
Ma'am, actually, I'm telling you, if I can intervene here. See, fibrinogen concentrate is not getting this popularity in the developing nations. If you go to the Western culture, you go to the Western, the European and American side, every trauma patient where the fibrinogen concentration is lowering down, rather than going for the FFP or going for the cryoprecipitate, people are going for the fibrinogen. It raises the fibrinogen level like anything. And the only problem with the fibrinogen concentrate is the cost factor. It's not about the replacement is immediate. The replacement is free of many reactions. Also, adverse events also are protected from the fibrinogen concentrate. But in developing nation, it has not gained the advantage, not gained the popularity because the cost involved in its formulation is quite high. That's why we are not following those things. And all the blood transfusion guidelines, they are also variable, highly variable throughout the globe, whether it's a Europe or Australian or American or the African or Sub-Sahara. Everywhere the guidelines are different, the indications are different. You are giving the blood transfusions, you are giving the fibrinogen, you are giving the cryoprecipitate. There are so many factors which dictate the transfusion of these on individual basis. There are no blanket guidelines for any particular transfusion type of scenario.
And also,
Absolutely.
sir, at the end of the day, it is going to be the clinical judgment for that particular patient that you have on hand. Unfortunately, sir, fibrinogen levels, there's such a lag period in getting that report on our hand. Most of the centers would not get a fibrinogen level at least 8 or 10 hours down the line, and the dynamic picture changes. So that's something we as quality people will also need to address, that how do we get these values faster so that we can actually take better actions and avoid all the coagulopathies. We are number one in trauma, number one in head injuries. So our trauma protocols for getting these products, definitely we need to work as anesthesiologists with extremely knowledgeable transfusion medicine guys. We are lucky to have Dr. Shivram, who can address so many queries, and we can take this forward. So how do we cover the gaps which exist right now in our systems, you know? So yes, that's there. Dr. Ridhima, moving on to, yes, Dr. Vanita, continue, please.
Yes.
You wanted to
So
say
I
something?
also agree with Dr. Bajwa. There are no hard and fast rule of thumb here as far as transfusion is concerned. Even people have gone for 2:1:1 ratio, and studies have been done, clinical trials have been done. So the outcome does not vary, although the amount of bleeding time is less when you go for 1:1. So fibrinogen concentrate, I'm sure, also will come up following any guidelines or RCs. So till that time, we will have to continue with what we are doing under our existing scenario and resources. So coming to the adverse effect of transfusion. Sorry, sir.
Okay.
Ma'am, I just want to update is the guidelines. There are advisories. There are everything. You talking about the lag period of 8 to 10 hours. The lag period is not more than 30 minutes. If you want to give fibrinogen concentrate, not more than 30 minutes. But if you go by thromboelastography, it gives you around 10 to 15 minutes. And if you go by the rapid analyzer by the blood, it takes 2 minutes, which has been developed by the Japan. So I don't think so. There is a lag period now when you are giving
the point is, how many units have TEG in India in their hospital?
That's why you have to calculate that. Shivraman sir has already given you a good calculation, and the fibrinogen concentrate, it's it's almost 3 times the cryoprecipitate. The same amount of the unit, you get a 3 times that of a cryoprecipitate. So I don't think so. There is a lag time there anywhere, which is you can say that we are not able to measure the level of fibrinogen in these type of patients. So the guidelines are already there. They are in place with the newer guidelines I'm talking about. I had just covered this topic in Singapore also, WC also, about the fibrinogen consent in the polytrauma patients. That's why I'm talking about those. Those are evidence-based guidelines.
Okay. Dr. Ridhima, we have our 60-year-old patient who underwent laparotomy, came with polytrauma, needed multiple fixation. He was an IV fluid. We checked his hemoglobin. It is still hovering around 4-ish. And so 2 units of packed cells were given to that patient. But now 8 hours post-transfusion, this patient is breathless. And if we look at his heart rate, it's 142, BP is 140/90, oxygen saturation has dropped to 85%. So how do we differentiate between transfusion-associated circulatory overload and TRALI, the dreaded complication of acute lung injury? How would you approach breathlessness post-blood transfusion?
It's a very important DD to make because most of the time the clinical features are overlapping. So I'll be only talking about the practical things to differentiate between two. So whenever there is a chance of TRALI, the patient might have a hypotension, and very important is the history of fever is very important, especially in the acute lung injury. Wherein TACO there can be a hypotension and lack of fever can be there, because it is a circulatory overload, so there can be an increase in the jugular venous distension can be there, and apart from ROLS, there can be S3 on auscultation. And very important thing is that there can also be a peripheral edema. So one of the things that you can do very quickly is that you can give a diuretics to the patient and check if the symptoms are improving after giving a diuretics, then it means that the likely diagnosis is can be a TACO. And other things that you can do is the pulmonary artery occlusion pressure, that if you have that already, though you can see if it is 18 mmHg or less, it means that is a TRALI, that is acute lung injury, and more than 18 is likelihood of that TACO. So also nowadays they are using this BNP, that is natriuretic peptide, is also used as an investigation. And if the values are less than 200 picogram per ml, it means that the trolley is there. And more than 1200 picogram per ml, that is considering of TACO. And leukocyte antibodies can also be seen in trolley, which is not seen mostly in TACO. But this can be overlapping. So mostly you have to use your clinical sense to rule out everything. And also there are pulmonary fluid can also be taken. In TACO, they are mostly low protein filtrates are there, whereas in trolley there is high in plasma protein. So all this thing we have to take care, and we have to see clinically the judgment. The most important thing is to see the history of fever, and
Is there any role of
diabetic.
Yes, Dr. Ridhima, is there any role of pro-BNP in differentiating TACO and trolley?
Yeah, so pro-BNP, if it is mostly it is increased beyond 12,000 or 1200, it is most likely of a cardiogenic sort of circulatory overload. If the values are around values are 100 and post-transfusion it is less than 200, it is mostly a trolley. So they have been used nowadays that BNP levels pro-BNP levels can be used to differentiate between this cardiogenic and non-cardiogenic pulmonary edema. And overall,
yes.
Dr.
Shivram,
Kiran,
sir, what
Dr.
are the
Kiran,
tests you will do to... Yes,
I
please,
just
sir.
want to add that so whenever there is breathlessness following blood transfusion, you must consider three things. One is trolley. Trolley comes with fever because there is granulocyte antibody and there is neutropenia. This is what is responsible for the fever. Whereas if you have a history of lot of transfusions, fluids or anything, and along with that BNP levels elevated, you would consider TACO. Then there's the third entity called TAD, transfusion associated dyspnea. This is a benign form, neither trolley nor TACO, but just patient present with breathlessness, which normally recover within 6 hours. It happens within 6 hours of transfusion, but patients recover on their own within 24 hours without much intervention. So these are the three things we must consider, in addition to maybe an allergic reaction, which can also present with breathlessness.
But that would be immediately within the start of that. Breathlessness is more at the initiation of blood transfusion. These ones are falling within 6 hours or after 8 hours for TACO or trolley, right?
Timing is very important. As ma'am said, it is 8 hours. Like anaphylaxis and urticaria present immediately, and these things take some time and hours to develop.
Here we also need to look for transfusion-related immune modulation, where we can have an increased incidence of bacterial infection following a transfusion. And the other common things that we usually see are the metabolic complications like hypocalcemia, hyperkalemia, metabolic acidosis, hypothermia. So these are the things also we need to look after.
And how would you replace the calcium? What are the current guidelines for replacing calcium in massive blood transfusion?
So we go by the ionized calcium. So the target is the ionized calcium. We have to keep it more than 8. So 10% of calcium gluconate, 10 ml calcium gluconate can be given. And you can also repeat it as per the ionic calcium. So in the normal ABG can give you the ionic calcium. So it's very easy to monitor there.
Yes, very true. Shivram sir, if the adverse reaction takes place, what are the tests you would recommend for us to follow up with?
Okay. I think the blood centers will automatically start doing minimum things to do whenever you report an adverse transfusion reaction. There is a form which most centers have, transfusion reaction reporting form, in accordance with Hemovigilance Program of India. So we check we repeat the blood groups with the pre-transfusion, post-transfusion samples. Then we repeat the cross-matching. Earlier, donor grouping will have been done by pooled cells normally. Patients is recommended is 3 cell. So now we go back and check donor also using 3 cell panel. Then the most important test that we do is a direct Coombs test or direct antiglobulin test, because this helps to differentiate and whether there is an antibody that has newly developed or patient already had, if it's a case of autoimmune hemolytic anemia. So DCT is a very important test which helps to differentiate between a hemolytic transfusion reaction and a non-hemolytic transfusion reaction. So these are some simple tests. Besides ruling out, the most important thing is clerical errors, which are the #1 cause of death worldwide, except in the United States. In all other countries, clerical errors come first, then comes Raleigh, TACO, all these things.
Yes, yes. Lalit sir, how can we mitigate this human error? The one which is causing the maximum damage rather than these immune modulated reaction, it's a human error which causes maximum. So legally, to protect ourselves and also to save lives, what are the mechanisms in place that we must follow to mitigate this problem? Because even now we were discussing, and just few weeks back a patient died because of the wrong blood transfusion in Rajasthan, and there was major issue. So these incidents keep coming. So what are the protocols that we must follow when we give blood transfusion from safety point of view?
Yeah, ma'am. From legal point of view, one have to be documented the prescription. The blood has to be transfused because retrospectively it have means. Then the blood transfusion should be under supervision of doctor as well as trained nursing staff. Sometimes the intense doctor is responsible to transfuse, or new staff who is not having any training or exposed to that blood transfusion. Then after that, the main part is we have to confirm the patient identification that this blood is going to infuse the same patient. Maybe error that they have not seen the patient name and they transfer to some other one, maybe. As well as now, the main important part is we have to cross tally the patient name, registration, as well as patient blood group. Along with that has to be matched with the labeling that we received on the blood bag. As you had mentioned, because in Rajasthan there are 3 units has transfused of wrong blood. Patient blood group was O positive, and 3 consecutive A positive blood was
And in
given.
court of law, there is no justification and there is nothing any lawyer can do to get you out of this. That's actually absolute liability comes on a wrong transfusion. And in this time in 21st century, I think we would just have to make quality measures so strong that the entire checklist is done in the sense the repeated check, the patient ID, cross-rating, and it's not just one. There are 10 parameters which need to be checked when you start the transfusion.
Yes. And one more thing that we have to mention it on the ballot ticket that this was checked and blood bag number so and so is started at this time. I think Dr. Sim sir will agree with this, and we have to attach that label chart that received from blood bank. That is again a document.
Yes,
I would like to add one thing. In the West, 2 people compulsorily double check the blood grouping and typing. So I also like to add, especially because we work in the theater, that confirm that the case sheet that you're checking belongs to the patient in your theater. So there'll be multiple bloods which will be given. That is one. And 2 people, that means the anesthetist or the nursing officer or somebody, 2 people should double check, read out and confirm.
And
so that that reduces the human error before giving the blood.
And along with that, ma'am, one more important thing is that maybe the same, that is for the same patient that has cross-matched and tested, we have to check again the expiry.
Exactly. Yes, sir. 10 points that madam had told.
And is there blood clots present or not in the bag, or hemolysis is there? If we can able to appreciate, that has to be, if noted, then that has to be informed to blood bank.
Kiran ma'am, can I add something here?
Yes, sir.
Dr. Kalyani said about the checking of the blood by 2 people. I think in our Indian scenario, the way we have been taught in right from our post-graduation, a PG, a technician, a consultant, 3 people check the blood, right from our teaching, what will be going on. Now, if we go by the data accumulation in our country, where the blood transfusion reaction occurs, where the anaphylaxis occurred, it occurs mainly in the wards. It's mainly occur the places where the anesthesiologist is not available. I'm not biased toward anesthesiologist, but if you take out the data a very sincere manner, honest manner, I think the habits of operation theaters are very, very sincere. The most of the reactions occur in the wards or some other areas where the critical care or the anesthesiologists are not giving their services. So that also a thing of concern. So how to bring up those things? Somebody has asked in the chat box about the USA doing the double check and the minimal clerical error. I think it's a human nature. We have to treat the wards and we have to do the training in the wards and other areas where the maximum transfusion reactions occur.
I agree with you, sir. And I think thanks to all the protocols, we are making anesthesia safer and safer in India.
Oh, yes. Oh, yes.
So,
Yes.
yes.
Dr. Kiran, I
Shivram,
must come
sir,
here for
I'm
1
very-
minute. You have to give me 1 minute. I want to make some very important comment.
Yes, sir. Yes,
because
sir.
this I feel is the most neglected thing in our country. See, you might do grouping, cross matching with the best of machines, best of technicians, but if the sample itself is wrong, everything goes wrong with it. So good blood centers today, we follow a two sample policy. The first sample for blood grouping and antibody screening. This sample we don't use for cross matching. For cross matching, you have to give us a second sample. We'll repeat the grouping and tally the two. Then only the grouping report becomes valid. That is one point. Then everybody spoke about how two people should check the blood bag, two people should check the patient and everything. You mentioned, so the most important thing is how do you check the patient? Case sheets are not acceptable. They can be misplaced. The only way to positively identify a patient is with the wristband. And in the absence of the wristband, two people should identify the patient. These are the guidelines. One is the wristband, only way. If there is no wristband, two people who have seen the patient earlier should identify the patient. Lastly, then which document will you use for saying this blood bag is A positive and this patient is also A positive? You have got a cross-matching report along with the bag that is released in the middle of the night by a technician. If he has written A positive on the blood bag, he will have written A positive on the cross-matching sheet also. It both could be wrong and both will tally. So my suggestion would be a blood grouping report, blood grouping antibody screening report, make it mandatory in every institution. Keep that hard copy in the file and tally every unit of blood with the properly authorized blood grouping report. Don't bother about the cross-matching report. These are just legal papers which we keep on filing. So two sample policy, the identification of the patient only using wristband and use only the blood group report properly authorized by the medical officer to know the blood group. These three things, if we follow, we will have no problems.
Excellent point, sir. Excellent. Sir, I also am curious because we had a lot of buzz around hemoglobin-based oxygen carriers because they are blood group neutral, they don't have immune reactions, longer shelf life. The initial clinical trials were not very promising, the high incidence of myocardial infarction and other things. So how are we currently placed on engineered blood and products like that? Is something coming in the market? Do we see anything hitting or we are still long way from it?
Has anybody used perfluorocarbons in this panel or in the audience? Probably the answer will be no. But the perfluorocarbons, I mean, they have used in some clinical trials. They have been approved now in the US. They have been used during angioplasties. But the drawback of this is they have a very short shelf life of a couple of hours. So when a person is bleeding, how often will you go on giving perfluorocarbons after carbon? It's endless. That is why perfluorocarbons have not caught on as a real red cell substitute. Other than plasma factor concentrates, we really don't have substitutes for red cells or platelets.
Yes, very true, sir. And there are a lot of questions. Bajwa sir, how are we placed on time? Should I continue or should you let me know? Because I know this is like...
we have 20-25 minutes left.
परफेक्ट क्योंकि दिल में एक ख्याल हो तो बताऊं, बात एक हो तो बताऊं, वो मुझसे कहते हैं बीटी के बाद जो बीता मुझ पे साझा करो, एक शाम में मैं क्या क्या बताऊं. So I am really fortunate to have, we all are with such a distinguished panel. So I think we'll continue for another 10 minutes before we take the questions. Yes. Right, sir. Sir, Jehovah's Witness, because this has come up so many times. Lalit, sir, would you just briefly tell us about the legal implications of Jehovah's Witness and blood?
So we have to respect the autonomy of patient. In this religion, they don't want even that from other creature we have to save another one. Even they will not put the blood in the mouth also. So we have to respect that, and accordingly we have to plan with the alternative means.
Yes, yes. Shivram, sir, I just want to, because we have a very educated audience, but could you highlight something about imputability in blood transfusion, sir?
Imputability with respect to blood transfusion refers to when there is an adverse transfusion reaction. A patient develops an adverse reaction, let's say fever following a transfusion. How much of it is because of transfusion, or could it be because of the underlying disease? For example, if I were to give a patient a unit of blood and he develops fever, I culture the blood bag and I culture the patient, and both of them grow the same organism, then I can say imputability is definite. Whereas if they don't grow anything, then probably it is because of febrile transfusion reaction called by cytokines, I would call it probable. In addition, if the patient had an underlying dengue fever because of which he was transfused, then the imputability would further come down to possible. Then we also have like that definitive, probable, possible, unlikely, and excluded. We can even exclude blood transfusion at the cause depending on the underlying disease which the patient is suffering from. So this is what is meant by imputability. In addition to determining the nature of the adverse transfusion reaction, we also report imputability to National Institute of Biologicals, which is the which runs the Hemovigilance Program of India.
That's a very good, important concept, because litigation, but it's not necessary that every adverse reaction is linked to the blood transfusion. There has to be a proof of, the association. So that imputability, because many times you have hemolytic reactions and problems, and those do land up the purpras and the rejections, and you go into the court of law. So yes, that's there. Sir, other concept is autologous blood transfusion. Anyone in the panel could take up there. What is the protocol to collect blood? Definitely there are studies which show that it can cut down on the blood transfusion. Is it an option in Jehovah's Witness also as a technique, or even they do not allow that too? Because that's what people would want to know. Are they open to using their own blood?
No, Jehovah's Witness don't accept their blood also, because they believe that blood circulation, once broken, it should be covered with mud. That is what the religion says. You cannot put it back, so they will not accept it. Jehovah's Witness, you can try offering. I have currently one Jehovah's Witness. In fact, we can try offering some things. Like one is, I offer them, would you take plasma products? They don't have life, plasma cryoprecipitate. Would you like to take factor concentrates, which again come from human source, but which are available like PPC, fibrinogen, and which are available in the pharmacy? Some people accept this, and most people don't accept red cells and platelets. But of late, I have found some of their spiritual leaders. One of them told me that if you are able to give them 33% red cells, it is okay, but you should not give more than 33% red cell. So I presume 33% meant hematocrit. I added saline, diluted it to 33% and happily gave it to them. But not everybody will accept this.
Yes, because the packed blood cells hematocrit is around 55%,
55, yes.
which we are using as there. But if this one is there were other questions here in the thing where it was asked by Dr. Malika. Do we routinely use normal saline to reduce viscosity of transfusing RBC in neonates? Indu ma'am, would you take that, please?
Madam, you are muted.
Actually, I have replied to this question in the chat box. If we have a larger gauge cannula, many times we put the PICC line, or we have a minimum of 22 gauge cannula. Then blood can be given undiluted, but if you have smaller gauges like 26 gauge, it's good to dilute it.
A very good point by Dr. Shiva Sankar. The one measure that would reduce the mismatch reaction is by reducing unnecessary transfusion and over transfusion. I think that's a very sensible statement that we need to be very judicious, because I think it's not about just saving lives, it's also about saving bloods. We are short by 1 million transfusion every year, so we do have that responsibility of not exceeding the targets that are in the picture. Yes. Kalyani ma'am, what are the monitoring standards for the blood transfusion? For how long after blood transfusion we need to monitor, and what are the parameters we need to monitor?
During transfusion we monitor the patient routinely. Post-operatively, after 24 hours, depending on the patient need, either we do a point of care hemoglobin testing, or we would do a hematocrit and CBC in the post-op. The other testing, depending on how the patient is, I would test them. I routinely do not test specifically for blood transfusion, any specific test.
There's
Dr.
another
Kiran?
entity which
Dr.
happened
Kiran?
is the, yes?
Monitoring of transfusions normally is recommended at 0 minutes baseline for vital signs, 15 minutes, completion of between 15 minutes, only completion of transfusion, and 1 hour post-transfusion. That's important. But between 15 minutes and 4 hours, which you are transfusing, every half an hour you must go into the patient's room, say hello to him and come out, just to make sure that he hasn't collapsed.
Yes.
No need of
Yes.
documentation.
So the standards,
in
yes,
theater, it is continuously monitored.
If it is continuously monitored, it's fine.
We do more vigilant monitoring during anesthesia, which would be practically beat to beat. But we need to know, and our staff needs to know, that when a person has a blood transfusion, even 1 hour after the transfusions, the vital needs to be collected and documented on the file. That's when it kind of completes the loop. And if it's a massive transfusion, obviously the patient is in an ICU setting or a high dip where we anticipate that this patient could go into TACO, trolley, or delayed complication. They need to be in an environment where they can be monitored, the complications picked up earlier, and obviously handled accordingly. Yes.
The most important, they say, the first 15 minutes and the first 50 ml of the blood. Those are the critical times where you will actually catch a immune reaction or a hemolytic reaction. So those are the critical times. There was a question that do we need to warm the blood? So single unit transfusions need not be warmed. But if we are going for more than 1 unit, definitely that will make an effect on the temperature. So those would need to be warmed. But in an emergency, if we have a rapid fluid infuser, we could use that with a warming system. Maintain, sometimes it is a balance between maintaining the temperature and giving the fluid. So depending on that, in an absolute emergency, you can push the fluid in even without blood filters. And that's what I remember very correctly. Maybe Dr. Shivram can attest to that further.
I would not take blood filters away, even in emergency, because if you are in a resource rich, let's not compromise the filters there.
Yeah,
and because
in the sense,
massive
depending
products
on
are
the
going in many
emergency,
times.
like an aneurysm rupture and all, sometimes the
even
blood.
Yeah, I'll beg to differ there, because if we do have blood products, I would suggest we do use the filter. I would recommend filter even in front of infusion pumps, so that we ensure wherever we are quality people.
May I say for autologous?
Yes, sir. Please go ahead. Please go ahead.
Regarding autologous blood transfusion, if we are having time, we can take patient on blood from 4 to 6 weeks. Before that, we can able to take 4 to 6 units and 1 unit at the just before the operation started. So we can able to collect 4 unit blood, maybe in condition of rare blood, or we are not having scarcity of that. So patient 1, as well as by this we can reduce the transfusion reactions.
Yes.
What sir says a great value. You can collect blood that's called preoperative deposit beginning 3 to 4 weeks prior to surgery.
Yes,
but please remember, the last unit should be collected 48 to 72 hours before the day of surgery.
Yes.
If I may, the downside is if the patient doesn't need the blood,
Gets wasted.
the blood gets discarded.
Yeah.
It cannot be given to anybody. So.
And
There's
if you have to
another
collect
group
more
of
than 2 units, you will need to give erythropoietin and iron supplementation. You will not be able to collect so much.
Yeah.
True. There's another entity that we are when we send our patients in post-ops and they are in ICU for a long time, especially the critically ill one. They start dropping hemoglobin in ICU. It's a gradual drop which happens, but it's a significant drop over a period of weeks. So, what are the trigger guidelines for a patient who's dropping hemoglobin in the post-op? What we call the ICU hemoglobin drift. So, anyone would want to take that? Dr. Kalyani?
Yeah, so I did read up a lot about it, and there again the triggers are nearly the same, 7 grams, and again depending on the patient, but 7 grams is what I recollect from what I've read in the ICUs also, and reduce again the
in a perioperative setup, the trigger, it would be safe to keep a trigger around 8. Because small ooze, they may, with time, it will become a significant loss. And if we keep a trigger at low, then we might be harming the patient.
Yeah, and especially if they are cardiac patients, there are other comorbid risk factors. If there is a sepsis, definitely the trigger needs to be around 8. But however, having said that, this is one group where I think we need to be judicious how much we are sampling our patients.
Exactly.
Too much sampling itself, we lose blood in this patient. And in this group, another reason of this occult bleeding is that we should put them on proton pump inhibitor. And at this point, sending lot of blood investigation, iron, folate panel is not going to be value add-on. More important would be to avoid unnecessary labs. Can you come to a trigger point? Do transfuse your blood, which needs to be there. Yes. And anticoagulants, sometimes we are not mindful. We put them on for DVT prophylaxis, and then again they are oozing out. So need to strike a balance so that post-operatively we don't come to a situation where our hemoglobin is dripping, and now again we get into the cascade of transfusing the bloods. Yes. So there is this question I think we should address. Everyone wants to know what are the temperatures for different products at which they should be transfused, for FFP, for platelets, for blood. So what's the ideal temperature for transfusion of these products?
For transfusion, you simply transfuse at the ambient temperature. By ambient temperature, I mean 18 to 25 degrees centigrade. Storage is different. Red cells are stored at 4 degrees, platelets are stored at 20 to 24 degrees, and plasma is stored in the deep freezer below -30. But we will thaw the plasma, bring it to room temperature and give it to you. Platelets and red cells are released as it is. Don't warm any unit. Transfuse as you get from the blood bank. Start within 30 minutes, except in case of massive transfusion or exchange transfusion in a newborn baby. These are the only 2 indications for warming blood.
I see a question from Dr. Glady who says written that how much pressure should be applied to the pressure bag. The answer is it has to be less than 300 mm mercury because you could cause lysis of there. So never exceed beyond that because one is the caliber of your IV bore, which is a limiting factor, which you want to transcribe by the pressure. So do not exceed more than 300 there. And when we are talking about temperature, every 1 degree centigrade drop in core temperature would have chances of increasing your blood loss by 20%. So there's a huge increase of perpetuating that cycle. So even if we are not warming these blood products because we don't want bacterial and other complication, active warming of the patient is very crucial. So having warmers, covering convection, radiation, other losses, that becomes very important, so as to cut down on that temperature drop. So other measures are equally important, not just warming the blood products. Yes. I think, sir, we will start taking the questions because I don't want anyone to go back with an unanswered question. So I'm just going to start from the lower end. Okay, there is this question which is how to calculate the allowable blood loss. I'll take Dr. Indu ma'am take this. And Akhila, if you can just put the slide number 31. from Indu ma'am's presentation, because that also shows the allowable blood loss, which will come and will hopefully. Sir,
Well, we can.
while she puts that slide and Indu ma'am takes that, Akila, can you put that slide on, please?
Well, we can calculate the blood loss based upon the estimated blood volume and multiply it with the hematocrit initial minus the hematocrit target divided by the hematocrit baseline, whatever is there. And then based upon the estimated red cell mass also we can calculate. And the formula is estimated blood volume multiplied by the hematocrit, which was the starting hematocrit, right?
Yes. Akila has put on the audit parameters, so I will use this opportunity to highlight that whenever we are giving bloods, we need to audit our blood transfusion practices. Shivram sir, can you just take about 10 seconds to say what should we be auditing in our bloods? Sir, unmute yourself.
I will not go through this list. It's a very big list. Probably how we do an horizontal audit area wise to see every area is functioning, and a vertical audit where we follow a unit of blood from the collection till the very end, till it is issued to the patient or till it is discarded. This is a vertical audit of one unit periodically. Is a very good way to know that your system, everything is working fine. Then you can also do a bedside transfusion audit to check whether the consent form is being filled properly, whether you have a transfusion record is being updated, whether there's a delay in transfusion beyond 30 minutes. So all these things could be audited. Your turnaround time, how much time the blood center took to give you the blood in emergencies and routinely. All these are auditable parameters. This is a very vast topic, so I won't take much time.
Yes. Sir, what are the allowable blood switch? If you don't have one particular group, we can safely give this blood group without any legal hassle. So what are the switches which are allowed in blood groups? I don't have this group, so I'll use this. Everyone says, okay, O negative, AB negative. Those are also, there are resource crunches. So what are the blood switches which are allowed as per the
that was very nice,
demographics?
but nevertheless, I'll go ahead. We call a person as A if he has A antigen on the red cell and the opposite antibody anti-B in serum. So a B group person has B antigen on the red cell, that is why he is called B, and the reciprocal antibody anti-A in serum. If you come to AB group, you are AB because you have both A and B antigens on your red cell. But because you have both A and B antigens on your red cell, you cannot afford to have anti-A and anti-B in your plasma. So the AB plasma, a patient with AB group does not have any antibodies in the plasma at all. The advantage of knowing this is that AB plasma can be used universally for anybody else. You can give AB plasma to A group person, B group person, or O group person. That's about plasma. When it comes to red cells, all of you know that O group people don't have either A antigen or B antigen on the red cells. So O group is a universal donor, which can be given to A, B, or AB. And again, coming to AB group, because AB group people don't have any antibodies, they can not only receive O group, they can also receive A as well as B group. The RH factor is important, RH positive, D positive or D negative, only when you are dealing with red cells, not when you are dealing with plasma, because anti-D is not present in any of us, whether you are RH D positive or RH D negative. It's an immune antibody that develops only during pregnancy or only following incompatible D positive blood transfusion. So you need not bother about RH group when using plasma. AB plasma is universal donor. O group is universal donor. O negative can be given to anybody. O positive only to RH positive individuals. Only make sure that the patient whom you are getting, even in an emergency, has got H antigen to rule out Bombay, because O group cannot be given to Bombay blood group.
Yes. Now, this is a question. If you're transfusing intra, which fluid is most preferred if we are transfusing parallelly, multiple, you're giving blood with other? Dr. Ridhima, would you like to take that?
Can you repeat, ma'am? I just missed that.
When we are transfusing, obviously there's more than one blood going. So they probably, I think we are asking, which are the solutions which are compatible that can go parallelly with blood, that we can give. See, obviously, we don't like giving dextrose and we don't want to give ringer lactate and other things.
Lactate,
And
yes.
ideally speaking, even platelet FFP should be given alternately because you want to cut down on reaction. But sometimes we do have to give parallelly. So that's probably if we give parallelly, what are the transfusing introp that we would prefer? I think balanced salt and this if we are controlling. But if you
we should not mix any blood product with our ringer lactate solutions, and we should do it separately. And it is better to use that multi-port, drugs, separate infusion for your blood and your flushes of the medications. Because most of the time they are not compatible and they can cause problems. So different lines are very important, and specifically large bore cannula you should use it, and avoid mixing antibiotics or any other drugs with your blood and blood products, so that there is less chances of any anaphylaxis or reaction that you should take care of it.
There's a question, if you're transfusing O negative blood in a massive transfusion, Dr. Akila wants to know, in an emergency, what time do we switch to a group specific blood from O negative? I guess if you get it availability, you have. Dr. Shivram, sir, you are.
Yes.
Need to unmute yourself.
Today, when you are giving O negative red cells, there is hardly any plasma along with it. We have removed most of the plasma, and in fact, many blood centers also add sagam to it. So the quantity of plasma is very less, which means there are hardly any antibodies. And whatever little antibodies are there get diluted in the large quantity of plasma present in the patient's blood. So you can switch back to the patient's group once blood becomes available, no time limit. Yes. Unless you have given whole blood. Whole blood, you will have to wait and check the titers maybe, but not with red cells.
Okay.
In the same light, may I also ask Dr.
Sure, ma'am.
That's when we are transfusing to a woman in a reproductive age group, normally we would like to give a RH negative blood. So after how many RH negative can we switch over to an RH positive? I have read that practically, when can we do that?
The Rh negative patients should always receive Rh negative blood to the extent possible when it comes to red cells, even after they cross the pregnancy age, even beyond 45 years ideally, unless it's a life-threatening emergency. But when it comes to platelets and plasma I told you need not be Rh specific. Similarly, platelets do not have D antigen on the red cell, they're on their surface. So platelets actually can be given Rh positive or Rh negative. You can switch between the two, provided the plasma in which they are suspended does not have contaminating red blood cells. If it is pink in color, do not use Rh positive platelets to an Rh negative lady or a male also for that matter. But if the plasma is yellow or normal in color, then you can go ahead and transfuse the platelets. So Western literature will say that when you give Rh positive platelets to Rh negative lady, you can develop alloimmunization. Therefore, you should give anti-D. I don't think Indians develop so many antibodies. It is not a routine practice in India.
I said the platelet, there are a lot of questions regarding the platelet threshold. We did not address that, especially in preeclampsia patient, which is going for elective surgery, which is going for emergency surgery. So what would be our threshold for platelet transfusion in general for surgery and in preeclampsia setting? Because they are very refractory and they tend to get destroyed very fast.
The preeclampsia by per se does not determine platelet transfusion. If the lady is scheduled for a normal vaginal delivery, then 30,000 per microliter is good enough. If she is scheduled for a traumatic vaginal delivery, then you treat it like a major surgery and make sure she has at least 50,000 platelets per microliter.
And
otherwise,
what are the best?
Special.
Yes.
Sir,
how frequently should we?
Can I just comment on that?
Sure.
Shivaram sir, rather than just going about the quantity, I think what about the qualitative assessment?
Quality of parameter.
That is more by going by the thromboelastography or by other parameters. I think we could not have a particular deadline for particular type of strategy. At this deadline, we should have this because I think it should be a range. And moreover, I think the qualitative assessment is always lacking. I think the test of thromboelastography comes in 30 minutes to 1 hour if we do those things. What about that, sir?
The qualitative assessment becomes important during a bypass surgery, let us say. Even if the platelet count is 1 lakh or 1.5 lakhs, the machine renders the platelets dysfunctional. So in such a situation, we go ahead and give platelets irrespective of the platelet count. So otherwise, it is not practical to routinely do a functional study on the patient's platelet or the donor platelet. I don't think it is done routinely anywhere. So when it comes to platelet transfusion, you simply go by numbers. Only when you encounter a difficulty, then you go ahead and investigate further.
Because sir, we had in dengue patients, whenever they came, so we were always seeing at what level the trigger should be what level, because every individual patient is different.
Yes. See, in dengue, the anti-NS1 antibodies which are directed against the dengue virus cross-react with the platelet antigens and destroy them in a matter of hours. So WHO does not recommend prophylactic platelet transfusions at all in dengue. So perhaps if there is any other coexisting risk factor, maybe you can transfuse platelets at around 10,000 per microliter when it comes below 10,000. Otherwise, there is no indication for platelet transfusions in dengue unless the patient is having a mucosal bleeding, not even skin bleeding.
Yes. The bleeding criteria is important, yes. Yes. Okay. We do ask for best. How much colloids can be used to tide over the crisis till blood comes, and the role of cryo in trauma? I think we have addressed that.
Majority of the questions have been addressed, ma'am. I have seen it.
Most of the questions have been addressed by there, but if we still missed out on, I would like all the esteemed panelists to take 45 seconds to give a key takeaway home message regarding blood transfusion to our audience. 45 seconds. One thing that resonates the most with you, the key points that we hope that the people take over. Indu ma'am, you can take over.
Well, the blood, like any other medicine, should be used judiciously. And when we are looking at the algorithms or guidelines, we come to know what should be done. But we must know that what should not be done so that we don't harm our patients. So primum non nocere, no harm.
Yes.
I'll go next. So
yes, please,
I always say restrictive blood transfusions. Think twice before you give blood. But in saying so, please monitor the patient clinically. We could miss out hypovolemia. Take charge. Look at the tachycardia. I feel in most patients, if the tachycardia doesn't settle, reassess the need for blood in an operative setting. There might be a loss which we have not seen, which we have not calculated, like a retroperitoneal collection. So I would suggest that if clinically the patient is not improving, reassess, recheck the patient, that we might have missed out on a collection which is not seen.
Very rightly said, ma'am. Yes, reassess.
Dr.
Lalit,
message is documentation. You have to document. It is in current era from court of law, important one, and hemovigilance. When from starting of collection to transfusion, we have to observe each and everything, the blood collection, the donor screening, all aspects has to be taken care.
Very true, very true. Dr. Ritima?
I think a complication of blood transfusion are life-threatening, and as Sir said, since 2005, it has been legal requirement to report all the serious adverse reactions, and it's high time. As we will prepare patients in the PSC, we should pick up the high suspicion of index patients and make a multidisciplinary approach with our surgeon and involve the hematologist very rightly, and institution protocol to follow the massive blood transfusion boxes so that there are less chances of any patient dying of because of bleeding or mismatch, and we should adopt for restrictive techniques than liberal.
Oh, very true. Yes. Sibram, sir.
So one thing I would say, please do not wheel the patient into the OT unless you have a blood grouping report and you have made sure that blood is available, at least in major surgeries. Don't feel bad if we ask for 2 samples, one for grouping and one for cross-matching. It is in the patient's interest. Please train your staff to identify the patient correctly using the wristband and identify the blood band using a document appropriate for your setting. Then make sure that the blood that you get at least comes from a blood center which has got an LJ chart. When it comes to massive transfusion, it is good to give plasma and platelets early rather than late, but there is no need to always follow 1:1:1. Don't get carried away too much with these ratios. Thank you.
Thank you, sir. Thank you.
So
It has.
message
Yes,
would be,
Dr. Vinny.
yeah, treat blood like a drug and use it only when it is absolutely indicated, and be aware of the adverse effects. However, in a trauma setup, please have a a low threshold to give blood, because we will never know, there could be occult bleeding happening. So a trauma patient would always qualify for an early blood transfusion.
Yes, we need to give right amount, right time to the right patient in all the times. That's the carry home mantra for blood transfusion. Yes, and the pillars of the patient blood management are very clear. We need to revamp our anemia thresholds. We need to be restrictive. We need to be totally sterile. We need to be very conscious of our decision rules, alternative methodologies to cut down on blood loss, to optimize our patients, and take away some of the habits that we have carried over for generations, but which do not make much sense. And I apologize if we missed any of the questions. I am sure this is a forum. Somehow, if we can maintain a continuity and take those questions, we'd be happy to do so. And I'll pass the mic back to Bajwa sir and to the coordinators. And I'd like to thank Dr. Madhura for seamless coordination, Dr. Akhila, Dr. Malika, and making this such a meaningful and value add-on session. It's been an absolute pleasure and honor to do this with you. Thank you so much.
Thank you so much.
Thank you, Dr. Kiran Madam, because I know selecting you for this moderating this session, because when you said yes, so I think it will be one of the very good session. I came to know on that day only. So before I think going for the other proceedings, I will just like to convey. First of all, I like to ask if Dr. Vimeshwar sir or Dr. Divetya sir are here. Dr. Manoj, just try to find out. Dr. Divetya sir or Dr. Vimeshwar sir, because they were busy at that time when we started the session. See, we must be actually, if they come out, think I will be just waiting for them. But before that, I think we can proceed for honoring our all the eminent panelists today, as well as the moderator. Just give me a 20 seconds. Is my screen visible? Is visible?
Yes, sir. Yes.
So, first of all, importantly, Dr. Kirandeep Sandhu madam, she did a wonderful job today. And with her, the flow was flowing like that. I was thinking of part 2. No, this part 1 is not complete. The part 2 can be there because many questions remain unanswered also.
Yes.
Because shortage of time, it's a very, very important and very large topic. So anyway, thank you, ma'am, for moderating such a wonderful session.
Thank you. Thank you, sir. Thank you, sir. And I kudos to all the audience for beautiful questions that they kept on asking, and really a pleasure, sir.
Yeah, thank you, ma'am. Then Dr. Kalyani, ma'am, I think you are also one of the most, I think all the panelists, I can't say one by one, but everyone was, master in their field, especially regarding this transfusion practices. They are not easy to, grasp, and then you develop on all the difficult questions asked by the audience as well as our superb moderator also. Thank you, Kalyani, ma'am.
Thank you, sir. Thank you very much, sir, for this wonderful opportunity to
Yeah.
participate in this discussion. Thank you very much, sir.
And I can say Shivaram sir was superb. More than my expectation, actually. What I was expecting, more than that. So he was simply superb. Shivaram sir, thank you very much. And I will love to be associated with you in the future also with such webinars, especially on this hematology and blood transfusion, sir. Then Lalit sir, as usual, he is always our very senior person of our ISA and the principal of a college, senior professor, and his experience always is very useful in all the classes, in the webinars. So thank you, sir, always. Not
Thank
for
you,
just
sir. Thank you very much.
always, sir. Thank you very much, sir. And Hindusan ma'am, as usual, you know, the special pediatric transfusion, which is another challenging area. I think you did a wonderful job. So we are really thankful from bottom of our heart for sparing
Thank
this.
you.
And Dr. Benita Panigrahi, ma'am, you simply superb. And you know, you have all the knowledge, I think, regarding the latest transfusion practices. So we are really, I think, impressed by your knowledge and presence of all the knowledgeable forwards you have put in this webinar, ma'am. Thank you very much, ma'am. And Dr. Ridhima, she is, I think, one of the most youngest of the lot here, but she has got a huge knowledge also. And thank you, Dr. Ridhima, for coming to on this platform and sharing your knowledge.
So it was informative for me also, I think not only for the listener. Thank you for the opportunity.
And especially to our these youngsters, these our screen coordinator, Dr. Akila and Dr. Malika.
Thank you. Thank you so much.
And really good. I think you people are infusing the confidence in the youngsters to come on the stage on the national platform. So it's very, very nice screen coordinating. And real thanks to Dr. our Manoj Kumar, Dr. Madhuri, and Dr. Nishan. They are the Dr. Manoj, the program head, and Dr. Madhuri and Dr. Nishant are the real coordinators who help me in this type of compilation of these type of webinars. I think Dr. Devetya is here. Devetya sir, can you unmute yourself? Devetya sir, can you listen to me, sir?
Yes, can you hear me?
Yeah, audible, yes, sir. Good evening, sir.
Yeah, good evening, Dr. Bajwa. So sorry I didn't join at the beginning. I was
No,
held
sir,
up in the
Manoj,
ICU.
You were in the ICU, sir. You got it.
Actually handling a post-massive transfusion patient.
Oh, great.
But yeah, so I did hear a lot. The last 1 hour I've been hearing while driving back home. So I think it's a excellent new beginning to a new series of the clip, and very practical topic, brilliantly moderated by Dr. Kiran. So congratulations for that. And extremely informative. All the panelists did a great job. I have only one extra comment to what Dr. Shivram said about identifying the patient from the bracelet or the wristband. And that is when you do the surgical safety checklist, right in the beginning, right? That is the time you need to make sure that the name on the bracelet is the same as the name of the patient. Okay, yes. So that's one further sort of check, because there has been the occasional disaster when the wrong bracelet has been on the wrong patient. Sometimes that can happen, rarely. But I think very practical, very informative, and congratulations to the whole team for bringing for this sort of webinar. And I think we look forward to many, many more informative, practical, and academic programs like this. Yeah. So I thank you to all the panelists for all the knowledge and wisdom that they have imparted to all of us. And I'm sure all of us will be much better off in our practice and in our knowledge at the end of this. And at the end of it, our patients should be safe and we should be safe. And I think this sort of webinar has served the purpose. Thank you very much.
Thank you, sir. Thank you very much. I request Dr. Manoj Kumar now at least to convey the thanks in the most formal way as a tradition of ISA. Dr. Manoj, can you kindly unmute yourself?
Thank you. Thank you, our Honorary Secretary, Dynamic Honorary Secretary, Dr. Bajwa. So, good evening, everybody. As we come to end of yet another webinar of the CLIP series, it is my duty to deliver the vote of thanks to all who helped to make today's events. First and foremost, foremost, I would like to express my deep felt thanks to Dr. Devi Devatia sir, President ISA National, Dr. Ganesh Prabhu sir, President, Vice President ISA National, Dr. Bala Venkat Subramaniam, President elect ISA National, and Dr. Bhimeswar sir, Chairman Academic Committee ISA National, for their support and guidance for this event. I am very thankful to Sukhvinder Jeet Singh Bajwa, Honorary Secretary ISA National, for having taken the lead and organized this clinical practical oriented webinar series of the CLIP. Thank you, Dr. Bajwa. I would like to thank to today's CLIP series moderator, Dr. Kirandeep Sandhu Madam, whose knowledge and ideas benefited to all of us. Hats off to you, Kiran Madam. Thank you so much. I am very thanks to all the panelists of today's events, Dr. Lalit Kumar Regar sir, Dr. C. Sivaram sir, Dr. S. Kalyani Surya Lakshmi Madam, Dr. Indu Sen Madam, Dr. Vinita Fanigri Madam, Dr. Ridhima Sharma for their nice presentation, and you have answered all the questions very nicely and very well. My sincere thanks to screen coordinator, Dr. Akhila and Dr. Malika for their help in the conduct of this event. My heartfelt appreciation to Professor Dr. Madhuri Kurdi Madam and Dr. Nishan Sahai for their invaluable help as a coordinator for this webinar. My sincere thanks to past President of ISA National, all the ISA State and City Branch Office Bearer, all the members of ISA and past postgraduate students who attended the webinar and participated in the discussion. I would like to conclude with a note that we will meet in the coming CLIP series webinar that will be conducted next month. Thank you so much to all of you. Long live ISA.
Thank you, Dr. Manoj. Your vote of thanks encompasses everything, and it's you always lessen the burdens on my part for doing all the formalities. That was all required as a part of tradition. So it's a good thing. So before we just conclude at another 2 minutes, anybody wants to give any particular suggestion? So we can conclude after that. Anybody want? They can just wait. I think I have to make.
My question to Dr. Kiran, Madam. So, Madam, what is the variation of the blood transfusion during CABG perioperative period?
The basic fundamentals don't change. They're pretty much the same, but the threshold triggers are more liberal. We are not as restrictive in our cardiac surgeries. So the threshold, when we are saying we'll take at 7, I would say it put more around 8.5 for those patients. We say we need to warm, but we have to be mindful whether we are on pump or we are off pump. So all the advantage of hypothermia can be lost if we are too aggressive in losing. The temperature management becomes, so it becomes we are in the same fundamentals, but a lot becomes more fine-tuned and nuanced in cardiac surgery, sir. It definitely does. And the chances of having complications, chances of having massive tears and then requiring more product, it can become a very simple day can become very complicated in cardiac surgery very soon. Yes.
Like I can see lots of variation during for most of the patient from 2 to 3 unit to 12 to 15 unit of red blood cell infusion and platelet and other FFP infusion.
The
Dr.
thing is to
Kiran,
be
with your
judicious,
permission,
sir.
can I butt in?
Yeah. Yes, sir.
Dr.
Please do
Nivedya.
answer that. Yes, yes.
No, I'm not answering. I'm just giving you, I don't like these terms liberal and restrictive.
Yes.
I think we are all trying to do the optimal thing. And one of the things, of course, you have to look at the hemoglobin level. But at the end of the day, what we need to look at is oxygen delivery and adequacy of tissue perfusion. And you need to combine that with, say, assessment of adequate perfusion, like, say, lactate levels or acidosis or something like that. So,
it's not just one parameter. Very rightly said, sir. It's the entire. It's not just one parameter.
You look at
it's
the
entire
hemodynamics.
clinical sense. Yes.
Look at the hemodynamics, especially the tissue perfusion. And and like you mentioned, the cardiac patients need a slightly higher one, especially the ones with active ischemic heart disease or myocardial infarction. There's a randomized trial in an EGM very recently which says that you need a higher threshold for ischemic for myocardial. So look at the multiple parameters rather than just a number.
Yes. Yeah. And then the body is smart enough. It's giving you all the from simple tachycardia to urine output to your hemodynamic stability. There are so many parameters which are telling us what would be the right call to do in that patient, right? Very right, sense.
More importantly, artificial intelligence will be coming into the monitoring standards now very soon. So it will be making your life much, much easier. But before that, I think the time is quite high now. It's time to say goodbye for such a beautiful webinar today. Thank you everyone here without naming anyone. So it's a heartfelt thanks to everyone who had spared their precious time for this webinar. So we will be meeting soon. And we always end by saying long live ISA.
Long live ISA.
Long live ISA.
Long live ISA.